Hello, my name's Paul Coburn and I'm the clinical lead for allied health here at TAC and at WorkSafe. And today joining me to discuss physiotherapy and return to work through his recent webinars is Harry Papagoras. Morning, Harry.
Good morning, Paul. How are you today?
Very well, and yourself?
Excellent.
So he has just completed a set of webinars, and what we're going to do today is to go through a series of questions related to those webinars. When you've presented this in the past, there's a series of questions that tend to come up again and again, aren't there?
There's a lot of questions that come up, and we've presented together for many years, Paul, and we get the question about what about the miner, the hairdresser who can't cut hair. So I trust you'll explore these during this session.
So stay tuned for the miner and the hairdresser. But to begin with, we'll start with I'll just start off with the introduction. And on this whole rationale for return to work, because there is now an understanding in the medical and physiotherapy community that return to work is a good thing. But to a lay person, that sometimes sounds like the wrong thing. They might think that they're better off staying at home and resting. Why isn't that right?
It's not necessarily helpful to stay at home and recover just at home after a workplace injury, or any injury for that matter. When you look at the evidence, there's a lot of compelling evidence that supports getting back to work. As long as the work is good and meaningful and safe, the benefits to health, physical, psychological and social. There's also a lot of evidence suggesting that if you're off work, especially for prolonged periods, there's a lot of harmful effects to the injured person.
So they may be better off at work than they are at home in actual fact?
Yeah, as a clinician, if I want to look after my patient better, I'm better to focus on helping someone get back to work as long as it's quick and safe and durable.
Okay. So we'll go through some of the modules, and the first module I want to cover is the case study, where you talk about the way people certify differently. So in that case study, it's interesting when you present those stats that there's a lot of variation in what people do. Is there a right or wrong answer to the certification in that case study?
Before we talk about the right or wrong answer, the thing that is quite striking, as you point out, is the variation. The case is about an injured worker who hurt himself 2 days earlier with a back injury, and depends on whether they see a doctor, a physio, a trained clinician, an untrained clinician, an interested clinician. Depends what state, will depend on whether the person has time off work. And so you can sort of see from the case study that the time off work is not always a function of the condition. It can be a function of who you see and how you're certified. If you look at the right answer, you'd be looking at determining the person's functional capacity, which comes up as a function of what the person can do, what their abilities are, what they can't do, what their limitations are, what they shouldn't do, which is a restriction imposed by the clinician of what they know about the pathology.
So, with going back to those issues of can, can't, and shouldn't do, when we talk about what you can do, that's important to get people back to work. But by the same token, you point out in those case studies that, in fact, some practitioners miss the fact that the patient has said that they have trouble sitting, and that actually hasn't been put down as a restriction. So, specifying what people can't do is just as important as...
Yeah, correct. And an example, if I use an elbow injury as an example, if I've hurt my elbow, there's things that I can do. I actually have capacity. I can use my non-injured arm. I can stand, I can walk, I have cognition, I can do things. There's things that I can't do. I can't do forceful moves with my arm, I can't reach, and I may not be able to lift heavily. And as a clinician, I also may say to my patient, look, I also don't want you to do repetitive work or repetitive mouse work. And combining those three, I then determine what my functional capacities of my abilities, my limitations, and really what I shouldn't be doing as a function of my condition.
So this is really a skill, isn't it? It's not just let's get everybody back to work and get back on full duties.
No, the person needs to go back within their capacity of what they can, and shouldn't do. The trick then is to find suitable duties that match the person's capacity. If there's suitable duties available, the person will go back to work safely and durably. If they don't have suitable duties, then the person either will not go back to work, or if they go back, they actually may harm themselves. And so it really needs to be the marriage of determining appropriate capacity and then determining is there suitable duties that match that capacity.
Can you just distinguish a little bit more between can't do and shouldn't do? Because they kind of sound the same.
Yeah, so if I look at a knee injury as another example, I may not be able to to walk for long periods. But also, that as a doctor, I may also say, look, I really think you shouldn't be walking on uneven terrain or trying stairs. And they're things that I may not have tried as a patient, but as a doctor or as a physio, and I know about pathology, I may then suggest of really, you haven't tried this, but don't try. You shouldn't do this for your condition. Or if I've had something where I can't weight bear at all, the person's hobbling on crutches, and the doctor will say, look, I know you can get from A to B on crutches, don't stand for too long, but really don't put weight on your leg because you may delay your recovery.
Harry, you mentioned in your presentation that certifying no capacity should only occur when it's medically necessary.
Yeah.
Can you give me some examples of what is medically necessary?
Yeah, there's a time and place where the person actually has no capacity and can't function. And that's when we term that as medically necessary incapacity. Now, an example of that, if someone's in a hospital, or they've just had surgery, or they're on high-dose medication, they're drowsy and they're bedbound. The other example is where activity or work is medically contraindicated, where they may harm themselves, they may harm others, or they may harm equipment or damage equipment if they venture into the community. There are examples where the person really has no capacity, and it typically makes up a very small percentage of workers' compensation cases.
What do you mean by harm others, or and sometimes you talk about may actually damage plant? What are those situations?
So if I'm on medication, I'm drowsy and I'm driving along, there's a chance that I actually may veer off the road and harm the car and the pedestrian. So I really don't want to be a risk to the community by venturing out. And so in a case like that, it may be reasonable that the person has no capacity to function in the community.
Harry, we'll move on now to the certificates of capacity and some of the examples you raised there. There's been a theme of questions that have come through in the past when you talk about certifying, and clinicians obviously are concerned about their patients and they want to look after them. But there's situations, for example, where someone says, look, they've got a capacity to work, but they can't drive or catch public transport. Now, what do you suggest in those cases?
With those cases, you often see the person is deemed to be unfit for any duties because they can't drive. My suggestion to that is to certify the capacity and not the situation of the inability of whether someone can arrange car transport or taxi transport. So if I was certifying a case with someone with a fractured ankle, I would certify that case as primarily seated duties, no prolonged standing or no standing possibly, and also the person really wouldn't be able to drive. So rather than saying they can't work, I would say unable to drive. What that would then do would open the door to look at arranging taxi transport, carpooling, or possibly working from home if that was available.
You've actually mentioned that in past presentations where clinicians have said they can't work because of this transport issue.
Yes.
And then, as it turns out, they have no idea that the employer all along had access to transport to the work site.
Yeah, I had a discussion with a physio a number of months ago, and the person wasn't working for about 2 to 3 months. And the physio was at wit's end trying to arrange taxis and call the employer, the insurer. And I asked the question, well, how are they certified? Well, they're unfit to work. It's very hard to arrange transport if there's technically no capacity. So I suggested that the next certificate, get that changed and say unable to drive. And within a very short period of time, the person was actually back at work because taxi transport was arranged. The messaging is very different when there's no capacity because it's hard to initiate services versus there is capacity and the barrier is transportation.
So we as clinicians sometimes don't see that document actually determines what occurs. It can actually limit
correct.
what can occur.
Yeah, correct, because no capacity means they can't do anything. So if I'm trying to arrange taxi transport, I actually see a certificate and I look at it purely, it says, well, there's no capacity to function, to do anything. And so I'm not sure what I'm arranging a taxi for, but if it says I can sit, I can use my hands, I have cognition, I can do other tasks, and the barrier is transportation, if I say unable to drive, it then may stimulate me to arrange transportation, or again, as I mentioned earlier, if there may be work to do at home, in their case where I've seen where we have arranged work from home if it's available.
All right, well, what about the example that people bring up every single presentation, and that is the small employer? And I think you've got to the point now where you can trademark the term Bob's Plumbing. So tell us about Bob's Plumbing.
Yeah, so we use Bob's Plumbing as an example of a small employer who's a one-man band, and him and Steve-O, for example, they work together. And a small employer may not have that many meaningful tasks that are small and light. A large employer, in contrast, has many duties. If you go to a supermarket, there's many jobs from facing up to doing other tasks, but a small employer really doesn't have that. So if I'm a clinician and I assume that Bob has nothing available, I may certify the patient unfit and they won't get back to work. But if I certify the capacity of the shoulder, and I say, with this injured worker, with Steve-O, he can't reach overhead, he can't dig ditches, he can't do forceful tasks, he may or may not go back to work. Now, Bob may have nothing for him. So with capacity, he may not work if there's nothing suitable. But I don't know if Bob needs estimates done, if Bob needs quotes done, if he needs to go to the local trade shop to look at different supplies. And so I would limit return to work and limit a meaningful task for Bob if I have this person certified unfit where he actually wouldn't work.
The other thing you've raised before is the possibility that he may never go back to that job. But by certifying without capacity, he then doesn't have access to VOC services?
Yeah, to retraining. It's very hard to look at retraining if the person has no capacity. If I see a certificate and I put a vocational hat on and I'm trying to help someone retrain or to job seek, it's very difficult to work out what I can get them job seeking if I actually don't know what their capacity is. So no capacity means they really can't do much. If Bob has nothing and we say he can't dig, he can't reach overhead, and that's a permanent restriction over a period of time, I may need to look at job seeking where there's work where the person could do seated duties, standing duties, or tasks that are lighter that don't require ditch digging or reaching overhead.
Okie doke. And we have to mention the hairdresser because otherwise we'll get in trouble with not being consistent with introduction.
Yes.
What about the hairdresser that can't use a right hand?
The hairdresser can't use the right hand. This probably comes up in every second presentation. Is I've injured my hand, I'm a hairdresser and I can't use scissors. And so most clinicians say that they can't do their job and therefore would certify them unfit. My suggestion in those cases is certify them with capacity and limit the use of the hand, because we don't know if the hairdressing salon may have other tasks such as Bob's plumbing. There may be front desk work, there may be other activities that the person could do that's meaningful to that environment, in the hairdressing environment. As the research suggests, the longer you're off work, it's hard to get back to work. And so if someone's off work for 12 weeks, the chance of ever getting back to work is 50%. If you're off work for 1 year, the chance of getting back to work becomes about 4%, 4 or 5%. So the success or chance of going back to work diminishes as there's a longer time frame. And there's a lot of adverse health benefits if you're off work for prolonged periods. It's far better to get someone back to work quickly, as long as it's safe and durable.
And there's something about transition between light duties to full duties as opposed to no duties to full duties.
Yeah, it doesn't make sense to be sitting at home for a period and then go back to full duties. You're better off transitioning that where you introduce work with tasks that matches the person's capacity. As capacity increases, the work duties increase. So I may go back to work and limit myself to, or be limited to lifting for 2 kilos. I may then go to 5 kilos and 10 kilos. And as I do that, it's actually rehabilitative to slowly increase my capacity in the workplace, so I strengthen, I mobilise more, and I'm also socially and psychologically getting more adjusted to the workplace.
And does the evidence support that, or is it just your opinion?
No, there's compelling evidence to suggest getting back to work and having a transition rather than being off work. The counter to that really is really, if you're off work for a prolonged period, the chance of ever getting back to work really diminishes.
One of the other things that comes up is the employer's obligation to stick to the restricted duties, and that's something that concerns general practitioners and physiotherapists, that they're not happy about certifying some capacity because they're concerned that the employer will ignore those restrictions. Yes. What's your comments on that?
The principle that underpins that is clinicians don't want their patients harmed. And so if they feel there's a toxic workplace or a non-supportive workplace, they feel like keeping away from the workplace will assist them. Unfortunately, the evidence does suggest there is great harm in being off work, again, for prolonged periods. Unfortunately, if there's a bad workplace or a non-supportive workplace, having someone at home doesn't resolve the issue of a poor workplace. In my experience, and my recommendation is to certify capacity on what the condition is, what they can, can't and shouldn't do. And then if there's a workplace that's not supportive, have the worker discuss it with the manager. As a clinician, you can do that. Or if there's challenges there to get a third party, as an occupational rehabilitation provider, to come out and really to resolve the issues in the workplace. Unfit certification really makes that very challenging to manage workplace issues.
Harry, in the webinar, you mentioned that in the certificates of capacity, they relate to both work and at home. What
Yes.
do you mean by that?
When I treat a patient, whether it's work or non-work related, I always give instruction to a patient on how they should look after themselves at home and also at work. If you injured your shoulder, I would say, look, when you go home, don't hang up washing, don't wrestle with your children, be careful of chopping something in the kitchen. The certificate of capacity is really a communication tool to the worker, to the workplace, but also the worker of what their capacity is. And so it doesn't make sense that on one hand I can advise you to do this and not do this at home, but then have a certificate that says you're unfit for any task or any duties. So the certificate really should reflect on the person's true capacity. And when I issue a certificate, I tell the patient, look, what I've got on here of your ability to sit, to stand, to walk, to lift, to carry, to push and pull, apply this at work and at home so you don't harm yourself, you don't aggravate your condition. And so in principle, it's a great communication tool for the patient so they can really help their condition out.
Harry, I'm now going to talk about the flowchart.
Yeah.
What's led to the development of the flowchart? Why has it arisen?
Yeah, so there's a whole webinar of this return to work flowchart that I developed a number of years ago. In my work in looking at facilitating return to work and managing barriers to return to work, I'd be bombarded with questions from clinicians, from employers, from insurers, from the injured worker saying, I'm not going back to work because they're not arranging services, I'm certified unfit, I don't want to go back to work, they don't want to go back to work. So there's a whole host of issues and barriers that came up. And the first question I would always ask as a unifying question would be, but how's the person certified? And it struck me that I would always ask that as the first question. That underpinned the whole return to work flowchart. And by asking that question, I could then work out what the actual barrier was to return to work to then manage it accordingly. So if someone comes in and says, well, the guy's not working, and I ask how they're certified, and they're certified fit, I clearly knew that the problem was vocational. Either the person has no job to go to, so they're not job attached, which means I'd look at job seeking, or the employer was unable to or unwilling to find suitable work. And then again, the manager would be vocational. I'd probably need to get occupational services out. So that barrier would be managed with vocational type intervention. The second barrier that I would come up, if the person's not working, I'd ask how they're certified. I'd be told they're unfit. My follow-up question would be, is it medically necessary? And if it was, then I knew the condition was severe enough that the person had no capacity. The management would really be managing the condition and setting expectation of when capacity would increase. The third one, that was probably the more common one, is the person's not working, they're certified unfit, and it's not medically necessary. And here the certifier I would deem as the barrier, that they weren't certifying correctly. And there's many reasons why a certifier may certify unfit, from what the patient says, what the employer says, what their beliefs are, but ultimately the certifier was not certifying correctly to open the return to work door. And that led to the development of the flowchart and create a systematic approach to identifying and managing return to work barriers.
One of the things that you've spoken about before that's a little controversial is your position that knowing the workplace is not necessarily the best thing for the clinician. Can you explain that to us? Because that sounds a bit counterintuitive.
Yes, many years ago, I was involved in developing and creating task analysis, and I even helped create for Australia's largest employer, where we made a CD-ROM of every job task that was available for this employer. We gave it to all of our doctors in their network and physios in the network. And we found that when we started talking about return to work, the messaging was a bit simpler than knowing what a B27 machine was or knowing what a ULD was. It was more along the lines of, but they've hurt their elbow. What can they do? What can't they do? What shouldn't they do? So that the clinician, the discussion point was pretend or assume they've got no job to go to. How would you certify the condition? And so I sort of realised that the knowledge of the workplace was not that important for the clinician at that point in time. Once you're certified with capacity, to know the workplace is critical to find a suitable job. And so the task analysis to me was essential for the employer and the worker, and possibly a rehab provider to find suitable duties. But I found it wasn't that important for the doctor or the certifier to actually know that at the first instance. And we've seen having better return to work rates as a result of that, because assumptions about the workplace or possible lack of knowledge of the workplace led to delays in certifying appropriate capacity.
Physiotherapists are well positioned for this, aren't they? They've got the skills of assessment, they're seeing the patient regularly, they should understand intricately what people, as you say, can, can't and shouldn't do. They're very well positioned to write certificates.
Yeah, physios in this day and age are really provide a lot of exercise-based intervention or functional restoration program. Very common when you see physiotherapists now that you'll be in a gym environment or an exercise-based environment. And from that, physios are well placed to work out someone's capacity on what they really can, can't and shouldn't do, of whether they can ride a bike or lift a box or push or pull a trolley for that matter. I think we are very well placed to either issue certificates or have a chat to clinicians about how to certify correctly.
Now, Harry, the final webinar is on the clinical framework, which has been around for 15 years, which is now a national document, but it's usually in relation to treatment. Why have you applied it to return to work?
There's a simple reason for that, is that I see return to work as treatment. I don't see it as a goal of my treatment now. I see the benefits of getting back to work or facilitating return to work physically, psychologically, socially. When I look at the clinical framework and I see it as a define of reasonable care for us as physios, I can see how return to work can fit in with all of the 5 principles. I can measure change over time, which is the first principle. I can see if someone's off work, back at work with limited capacity and increasing capacity, and hopefully getting back to pre-injury work. There's biopsychosocial benefits of getting back to work, as we mentioned earlier with regards to the research. There's an empowering aspect to returning to work where you can encourage your patient to understand their restrictions or their capacity and use it meaningfully at work and at home. Obviously, there's a functional goal. One of the examples in the framework in Principle 4 is return to work. And the last one is the evidence. There is a lot of evidence supporting return to work. You'll notice at the end of every webinar, I've got a very simple message, which is that we should actually see return to work as treatment rather than as a goal of treatment. And I really think that's a strong message to give to the profession and to the community.
Okay, so if you've come to this session first of all and you haven't actually looked at the modules in the webinar, please do. They're quick and concise and they're great information for you as a treater as to how to manage return to work. And probably the most important thing that we are well and truly familiar with now is that the more you focus on return to work, the better the health outcomes for your patient.
Yeah.
Thanks for your time.
Thank you.